Welcome, everybody. My name is Larry Hoffheimer, and I am the founder and chairman of the Macular Degeneration Association. Give you a little background on who we are and what the association has as its agenda is to basically provide an educational forum for patients, primarily with macular degeneration, but we cover a whole gamut of eye issues. In order to find out what our programs are and when you can listen in and participate, go to our website, because Macular Hope, HOPE.org, and you'll see a list of all the programs that we'll have throughout the year. Today's program is titled, What Type of Eye Doctor Should I Be Seeing? We have I want to thank our sponsors, Regeneron Pharmaceuticals, Novartis, and Notovision. You'll hear from them later from their support, primarily Notovision. I would like to give you a little background on why I started this organization 12 years ago. About 20 years ago, my mother had wet macular degeneration and lost her entire central vision. Those were in the days when they didn't have anti-VEGF treatments, and there was not much that could be done to save her sight. I took her to numerous optometrists, thinking she needed new glasses, and eventually she was diagnosed with wet AMD, and there was nothing that could be done. I felt that then it was a great opportunity to educate the general public when the numbers began to mushroom across the country and the world with macular degeneration. So, all that being said, I'd like to remind you that the questions you have should be addressed through the Q&A box at the bottom of your screen. Do not raise your hand. We have the two speakers this morning, or this afternoon now. One is Dr. Peter Keogh, who earned his diplomat in the American Board of Optometry in 2011 and was inducted as a fellow in the National Academy of Practice in 2013. Dr. Keogh has been practicing optometry since 1984. He's a graduate of Illinois College of Optometry and Indiana University and is a fellow in the American Academy of Optometry. Dr. Keogh has been active in Galesburg, Illinois, where he practices, and is past president of the Lions Club and former member of the Chamber of Commerce Board. He served as president of the American Optometric Association from 2008 to 2009 and was instrumental in the development of the Infant C program in 2001. He was named Optometrist of the Year by the Illinois Optometric Association. Keogh Eye Care is a member of Vision Source, a network of eye care professionals dedicated to be more focused on innovative and caring and trusting. So it's now my pleasure to introduce to you Dr. Keogh.
Thank you very much, Larry. Let me get the screen shared here. And I'm really honored and thrilled to be here today. And hopefully everybody sees my screen. What I hope to do today is to just give you kind of an overview. As Larry mentioned, I was president of the American Optometric Association back in 2008, which really afforded me the opportunity to travel all around the country, meeting with colleagues, optometrists, as well as ophthalmologists and many other disciplines within medicine. And I hope today to just kind of give you an overview of kind of my perspective on whether you're a patient who has macular degeneration, whether you are a patient who has family history of macular degeneration, but to give you kind of some ideas and some guidance a little bit on which eye doctor should you be seeing. As Larry mentioned, I have 3 practices in Central Illinois. You can see here I've been involved also with the World Council of Optometry as well. So I've seen the optometric profession and the ophthalmology profession kind of worldwide, which has really afforded me some unique opportunities. I'm really blessed to have had that. Honored to have gone through many of the programs, and I can tell you that we in our practice we see literally hundreds of patients with either dry or even wet macular degeneration. So we've got a significant familiarity with really caring for that entire patient. I've had the honor as well to work with some companies in the industry. I'm going to mention Optos in my talk today, and I was on their corporate board. I do believe that that technology is extremely helpful in diagnosing many eye conditions, but also early stages of macular degeneration. And as Larry mentioned, our practice is part of Vision Source, which is a network of about 3,100 offices around the country, where we really try to practice at a very high level. What I'd like to do today is to really start with what I believe is truly an underlying recommendation. And when I talk to optometry students, which I'm very fortunate to get to do a lot, I really try to remind them to really see every patient as that total person, and not just two eyes on a body or two eyeballs. And hopefully many of you on this will recognize this actor, Marty Feldman. But I think a lot of times what happens is that as healthcare professionals, sometimes we focus on a certain system, it's just the eyes. But I like to believe that the eyes are the window to our body, and they really allow us an opportunity in optometry and in ophthalmology to not only save sight, we get to save lives, but we have a chance to enhance people's lives in many ways that other healthcare professions can't do, whether that be making the proper referrals, making the right diagnoses, but also prescribing solutions that can really help patients. As patients sometimes go through phases of macular degeneration, even though their vision declines a little bit, we can help them with low vision aids in optometry. And I think that's an opportunity to see that patient as the whole rather than just those two eyeballs. I think the significant confusion comes, optometrist, ophthalmologist, and we'll even talk about optician in a minute. But I actually believe that there are oftentimes patients who will be seeing both doctors at the same time. But they'll have an optometrist, their primary eye care doctor, and they'll also have an ophthalmologist who's maybe their surgical doctor, or obviously if they're being treated for macular degeneration, they may be seeing an ophthalmologist or retina specialist as well. But unfortunately, even throughout the years, there still is that confusion. I like to say the confusion around the 3 O's. I'm an optometrist. We have technicians on our staff. We have opticians on our staff, and we have an optical dispensary. And that's a typical optometric practice. But what I find a lot of confusion is people will say, well, I go to the ophthalmologist. And in fact, they go to an ophthalmology practice that actually employs or sometimes has partners that are many, many optometrists within that practice. So oftentimes they'll see an optometrist, even though they think they're in an ophthalmology practice and think they may have seen an ophthalmologist. And that's really because over the last 3 to 4 decades, the profession of optometry has really changed. The scope of practice, the level of care that we deliver has really changed from that of providing eyeglasses and contacts primarily to really doing primary eye health care. And I like to say, rather than primary eye health care, I really am a primary healthcare provider because I really look at that whole patient. And I think many of our colleagues think that way as well. But as I mentioned here with ophthalmology, they obviously have optometrists on their staff. Many of them do, not all. And they have technicians, and some ophthalmology practices even have opticians on staff and optical dispensaries. But oftentimes people get confused with an optician, and typically, but not always, they will work for an optometrist or an ophthalmologist. Some will have a standalone optical store or dispensary. In about 21 states, opticians are licensed to fit glasses or contact lenses, utilizing the prescriptions that have been written by the optometrist or the ophthalmologist. Some states require up to 24 months of schooling. Some licensed states require 24 months of on-the-job training, sometimes 12 months. But many, like in Illinois, in my office, I do not have licensed opticians because it's not a licensed state in Illinois, but I call the people who work with the optical department, I call them opticians. And the reason is that they are well trained in the manufacture as well as the fitting and selection of eyeglasses. They actually cut the lenses to put in the frame. So they're very well versed at what they do. They're an extremely valuable component to the overall eye care experience. I can give the very best prescription possible, but if your glasses are fit poorly, if the bifocal or the progressive lens is not in the right position, you're going to think the prescription is actually wrong. And in fact, it's because those lenses weren't, or that frame and lenses weren't fit quite as well as they could have been. Things have gotten a little bit easier. You've all probably heard about the internet. You can buy glasses off of the internet. And I would argue that while you may save a few dollars, what you're really missing is you're missing an opportunity to have those glasses custom fit just for you. And when that's done, typically you're going to have your very, very best vision, just like you did when you're in that exam lane with the eye doctor getting your prescription finalized. As an optometrist, I'm using the definition here from the American Optometric Association. You know, primary eye health care providers who examine, diagnose, treat, and manage diseases and disorders of the eye. I do believe we also play a major role in maintaining the overall health and well-being of their patients. That's the definition from the American Optometric Association. And I really focus a lot on that last sentence that I read, you know, maintaining the overall health and well-being of our patients. This morning was a short morning for me, and 3 of the 4 patients that I saw have diabetes. And so in my role as an eye doctor, my role is to counsel them and ensure that they understand the importance of maintaining and really keeping their diabetes under control so that they're not going to have any long-lasting, long-term negative effects in their eyes, but more importantly, in their overall body. With diabetes, a lot of times if I start to see changes in the eye, it means there's also changes throughout their body and they need to get their blood sugar in better control. So I see myself as an overall health counselor as well as an eye doctor. An optometrist typically goes to college for 4 years, gets a bachelor's degree. Optometry school itself is 4 years. You leave that optometry school with a doctor of optometry degree. I believe it's 400 or so, 300 or 400 optometrists a year go into a 1-year residency, usually in a certain specialty. Sometimes that specialty would be contact lenses. It could be glaucoma. It could be retina, specifically with diabetes and or macular degeneration. And then a few of my colleagues have actually completed an advanced fellowship in a particular disease. And I know some of the fellowships that some of my colleagues have really focused on, whether it is either glaucoma or primarily the retina, because the retina is such a complex tissue, and macular degeneration, there's a lot of things with all the research that's being done to try to prevent progression from dry to wet, slow down the dry process. A lot of our colleagues are involved in a lot of the research around the world, really trying to slow down the progression as well as even the development of macular degeneration. An optometrist is licensed in each state to practice as a doctor of optometry. There is no, quote, specialty licenses or anything like that. Myself, I passed the original American Board of Optometry, which is board certification in what I call general optometry, meaning I have to have a broad knowledge of the entire profession, whether that be the refractive side, which is the eyeglasses and contact lenses, as well as the disease side. There are a couple other specialties, but the generally recognized national board certification is the American Board of Optometry, of which I did that, as Larry mentioned earlier. As we move to ophthalmology, ophthalmologist, by their definition, is an IMD, which I love that they say that, although, as you can see, an ophthalmologist can be either a medical doctor or a doctor of osteopathic medicine. They're a medical doctor or an osteopathic doctor who specializes in eye and vision care. Like optometry, they have 4 years of college. Like optometry, they have 4 years of medical school. But if you think about medical school, they're learning the entire body in those 4 years, where optometry focuses on the entire body, but really specially focuses on the neck up and everything related to the eyes and the visual system. Typically, a physician, once they graduate medical school, has to do a 1-year internship, and then they would go to a 3-year ophthalmology residency. They do need to pass an ophthalmology board certification at the end of that residency to be called a diplomate. Several, not all, ophthalmologists will do subspecialty fellowships. Those fellowships are usually 1 year, but sometimes 2 years. I highlighted retina and vitreous because they are typically all 2 years, because as I mentioned, the retina is a very complex tissue with lots of things going on. What's interesting is that a ophthalmologist is licensed by their state as a medical doctor or a doctor of osteopathy. They are not licensed as an ophthalmologist. All physicians are licensed as either medical doctor or doctor of osteopathy, but it's based on their training. So their residency in ophthalmology, their residency in pediatrics, their residency in cardiology. They're still just a medical doctor, that's their licensure. So sometimes it's hard to find physicians in a certain specialty, but if you're looking up from a license perspective, they're all licenses, just medical doctors or doctor of osteopathy. I do want to talk a little bit about all the subspecialties in ophthalmology, because when you think about the eye and what we call the adnexa, which is around there, and yet you have to remember also that the eye, when I talk to my patients, when I'm educating them about the back of their eye and their eye health, I like to use the analogy because so many people today are not familiar with a film camera, although I'll say that the retina is like film in a camera. And if they're probably under the age of 30, they've not really used film camera much. But I like to tell people that, you know, the eye is kind of like your digital camera. Back in the old days, you had to take your digital camera and put a cable between that and the computer to be able to upload the images. Now we do it with Wi-Fi and everything else, but that cable, I liken that to be the optic nerve, which we monitor for glaucoma, but it's about 1 million nerve fibers and wires, and they're connected in the brain and they're connected and actually become the retina. So you have this entire visual pathway that goes from the retina through the optic nerve to the brain. And we actually see with our brain. We use the eyes as our camera, if you will. But we actually are seeing with our brain. And so I like to talk about that. But that also gives you an idea why there's so many subspecialties in ophthalmology, because so many things can go wrong in and around the eye. Obviously, many of you are probably familiar with a cataract. When we say the anterior segment, that's typically from the iris, the colored part of the eye, forward. So there's a fellowship in that. There's one in comprehensive ophthalmology, which I would say would be just kind of an advanced program that's just kind of in general ophthalmology. The cornea, which is the clear, I call it lens on the front of the eye. External disease, which would be the eyelids and the inside of the eyelids. Glaucoma, many of you are familiar with that. That's a progressive disease of the optic nerve. Typically, we think of glaucoma as just high pressure, but in fact, glaucoma is actually a disease that progresses of the nerve. Neuro-ophthalmology and the orbit, which is around the eye. Neuro-ophthalmology really deals with that whole visual pathway as well as the brain in many, many ways. Ocular pathology and oncology, obviously cancers around the eyes. You know, retinoblastoma is a childhood cancer. It's one of the most commons. Oculoplastics, which would be considered a plastic surgeon around the eye, so the eyelids and around there. Pediatric ophthalmology is strabismus. That's for eyes that turn, but it's also just a pediatric focus. But even as an adult, if you have an eye that turns, you're typically going to see a pediatric ophthalmologist because they're the ones that are most skilled in actually doing the surgical procedures for strabismus. Refractive management and intervention, that would probably be tied back more to things like LASIK that you may have heard of, but it could also be related to cataracts because of the implant lenses that are there. Retina, we're familiar with that, and the vitreous, which is the gel inside of our eyes. And then uveitis, which is just an inflammation of the eye, can be very severe. So that's why there's a subspecialty in that. But what I really like to focus on for a second is to explain the differences between primary care, secondary, and tertiary care. You know, primary care, and I got most of these definitions from the organizations that are involved with them, includes health promotion, disease prevention, health maintenance, counseling, patient education, diagnosis, and treatment of acute and chronic illnesses in a variety of healthcare settings, but typically in an office setting, or, you know, maybe a nursing home and things like that. The focus on the person and not the disease. They consider all things related to their health. They integrate care when there's more than one problem. They take care of most of the patient's conditions most of the time. And actually, that's what I believe that I do as an optometrist. I'm taking care of most of their eye and visual needs most of the time. But when it's necessary, I'll refer to either a secondary or tertiary care as a condition warrants. Good example being cataract surgery. Secondary care is provided by a specialist or a facility that's usually upon referral by a primary care physician and requires more specialized knowledge, skill, or equipment than that primary care physician can provide. Many what I call general ophthalmologists, so they've done just their 3-year residency, do cataract surgery, and they're extremely good at it. Some of them go on and get a fellowship in even more advanced care when it comes to cataracts, but most of the time a general ophthalmologist, if they're still doing surgery, are doing cataracts. Oftentimes when I have a patient whose glaucoma, regardless of all the treatment that we've been doing, still advances and they may need some surgical intervention, we would refer to a glaucoma specialist for that. Obviously, many of you have probably heard of LASIK, which is to try to change the refractive error of your eye surgically. And then obviously when a patient goes from dry macular degeneration to wet, we're going to need to send them to a retina specialist. And obviously with a retinal detachment, that would be another one. When diabetic retinopathy becomes extreme, we oftentimes have to, or needs treatment, we'll send them to the retina specialist as well. I'm very fortunate. I live in West Central Illinois. I'm about an hour and 40 minutes away from the University of Iowa, which would I consider be a tertiary medical care center. Very specialized medical care, usually over extended period of time. It's for those advanced cases or complex things, or patients who have multiple diseases. A lot of times there's a need to have many of their conditions treated at the same time. So going to a medical center oftentimes is best place. We have some amazing eye hospitals around the country where they have pretty much every discipline in ophthalmology, as well as many optometrists on staff. Sometimes patients with very complex eye conditions going to an eye hospital or an eye center that's really I would call it a tertiary care center, really makes a lot of sense. Cancer in and around the eye, that's one place where most of the time, even an oculoplastic surgeon in a practice setting would send cancer to someplace like the University of Iowa to just really make sure everything's going on correctly, and as well as complications from like retina surgeries and eye injuries. So let's talk a little bit about our topic today is, which doctor should I choose? Let's assume that you're someone who has a family history of macular degeneration, but you've never been told that you have it yourself. I would say that you'd be wanting to see a primary eye care provider, either an optometrist or an ophthalmologist. I will share with you that 85% of all eye exams in the United States are performed by optometrists. So the majority of you are probably going to see an optometrist first. And oftentimes those optometrists are very hard to distinguish between an ophthalmologist at the level of care that they're providing. I'm oftentimes confused with an ophthalmologist because of the level of care that we provide in our office. But what I would encourage you to do is to think about your experience at your optometrist or your ophthalmologist. Think about the technology that they used. How much time did that doctor spend with you, discussing your situation, discussing your family history of macular degeneration, and things you can do to kind of prevent it potentially for yourself. Things like definitely no smoking. Try to eat lots of, proper foods. And I always joke with macular degeneration, I say, I'll write you a prescription for a glass of Pinot Noir every day. Because Pinot Noir wine is actually really good. It's got resveratrol in it, which is a great antioxidant. One of the technologies that I mentioned before is an Optomap. I obviously, by disclosure, I still work with them as a consultant. To me, it's really the ultimate way to see the entire inside of the eye. Even in a dilated eye, as I'm looking inside of your eye with whatever technology I'm doing, it's kind of like looking around a dark room with a flashlight and then trying to piece it all together in my mind. Whereas I like to say that when I get my Optomap image, I get to study the entire inside of your eye and then go back and focus on the areas that are really there. I was fortunate to be part of a poster that talked about all these changes that go out in the periphery of your eye that actually will lead to changes in the center of your eye near the macula later. So to me, this is a great tool for early intervention. Just an example here, you can see where the retina is and the vitreous that we talked about. the macula is a very small piece, you'll see this ultra wide field image, 200 degrees versus a typical camera that many offices would use. So in our offices, we have an OptiMap. Personally, I hate to practice without it if for some reason it's broken. I just feel like it's the best way to do an eye exam. One of the newer things, but it's actually an old thing, is the understanding that having night vision issues can be a precursor or a concern potentially of macular degeneration. If you, let's say you don't have been told that you have macular degeneration, but you're really struggling to see at night, there's a new technology. It's now very space age and virtual reality like it was in a dark room. Now you get to put this headset on that you see, but it's the ability of our dark adaptation is our eyes' ability to adjust from bright to dark or in dimly lit situations. And research shows that if that function is compromised, then it could be actually what they call subclinical or preclinical macular degeneration. And therefore, we're going to spend a lot more time talking about nutrition and not smoking and doing everything right, wearing sunglasses to protect that macula to make sure that everything stays healthy. We're fortunate to have this technology in our office, and those are the kind of things that you want to have a conversation with your primary eye care doctor to make sure that you feel like you're getting complete care. When I think about primary and secondary, as an optometrist, I diagnose conditions, I monitor those conditions, I manage the disease, whether that be through supplements or lenses. I treat disease. I treat glaucoma, prescribing drops. I treat things like conjunctivitis. But the bottom line is that at the primary care level, you're treating everything that you're comfortable to, and then you refer when appropriate, or if it's outside of the scope that you're comfortable. Secondary care, they'll diagnose and treat. Typically, they're going to return you back to your primary eye care doctor when appropriate, or if they can't handle it, they're going to send you off to a tertiary care. So let's assume that you have dry macular degeneration. And the first question I would ask you is, who diagnosed that condition? And the reason I say that is that if that doctor diagnosed the condition, and if they're suggesting ways to prevent progression, the good news is that that's probably the doctor that can monitor your condition over time. If by chance it progresses to the wet form, then you're going to want to definitely see a retina specialist. And that doctor who diagnosed it and has been managing it probably is very appropriate going forward, whether that be an optometrist or an ophthalmologist. But I think the important thing for you is, do you feel comfortable with the care and their treatment plan? In other words, what's the follow-up frequency? Is it every 3 months? Is it every 6 months? Or they say, well, we'll just see in a year. I would argue that anyone who has any form of dry macular degeneration should be seen a minimum of twice a year, plus being, educated on supplements, educated on diet, educated on not smoking, wearing sun protection, things like that. But monitoring their vision on a daily basis as well. If your doctor didn't have those conversations, then you might be time to look for another primary eye care doctor. What tests did they do at each visit? Are they doing retinal imaging like the OptiMap? Are they doing preferential hyperacuity perimetry, which you'll learn about a little bit later from our sponsor Nodal? We've actually been doing PHP, it's called, in our office probably for 15 or 18 years, well before some of the new technology that we have that can help see progression from dry to wet macular degeneration much earlier than just seeing it on an image or seeing it in the back of the eye. So again, this is a way to really keep a close eye on those patients with dry macular degeneration. We utilize Electro Retinograms, otherwise known as ERGs, to follow the function of the macula. If the function is declining, then it means that the progression of macular degeneration is getting worse. And then, as I mentioned, dark adaptation. So if your primary doctor got you on a good frequency of follow-up, you're doing many of these tests, then I would say you're probably in good hands. If they're not, you might start asking your friends for advice on who they're seeing if they have macular degeneration as well. Again, who diagnosed your condition? Here's one for you though. Let's say that you saw either, whether that be an optometrist or an ophthalmologist, and they said, oh, you have dry macular degeneration. I'm going to send you to the retina specialist to confirm it. That's not really primary care. That primary care physician, optometrist or ophthalmologist, should know whether you have wet or dry only. Unless they are pretty convinced that you actually have the wet form, then they would want to do that. Did they suggest ways to prevent the progression? 10 to 15% are going to progress from dry to wet. There is a debate a little bit on supplements and whether or not it can prevent progression. I totally believe that taking supplements won't harm you, but it could help you. Although you need to have some genetic testing, because some people shouldn't be taking zinc, even though that's a very common formula for macular degeneration. Genetically, they're predisposed to not do as well if they're taking zinc. Need to monitor very closely, but what's those frequency of visits? They should be based on genetic testing, on your current condition, and any recent changes or progression. And in general, dry macular degeneration, I like to say this is the ultimate eye salad. Dark green leafy vegetables, spinach, romaine, and kale would be ideal. Red, yellow, and orange peppers. And then I like to add salmon to that. And that's going to give you a very robust, healthy food. And if you can eat that 3 or 4 times a week, you may not actually need supplements because you're going to get so much good nutrition from that. Do they have a plan to monitor your condition? Have they suggested lifestyle changes, in particular nutritional things? There's really no need to see a retina specialist. And as a matter of fact, I can tell you they are very, very busy people. If you have dry macular degeneration, they really don't want to take a time out of their schedule to say, oh, you have dry, go back to your other doctor. They're going to follow you. So they really don't want to see you unless you convert to the wet form of macular degeneration. In this case, they're referred by the primary eye doctor, whether that be an ophthalmologist or an optometrist, or maybe even a retina specialist. In my case, I never refer macular degeneration or wet AMD in particular to a general ophthalmologist. I only refer retina to retina specialists. Part of that's medical legally, but I also don't feel that a general ophthalmologist can have the skill and expertise as a true retina specialist. So in this case, if you have wet macular degeneration, you're going to continue care with that retina specialist until he feels that your condition is stable, no longer needs any further treatment. Most of my retina specialists send that patient back at least once a year to see me, to refract them, to find out if there's any update in their glasses that could help them see a little bit better. But as long as they're still being treated, I'm not going to manage their condition anymore, other than just the visual side of it. They're going to continue to see that doctor, the retina specialist. Those doctors, once they feel like they don't need to treat it anymore because they've gone completely dry for a long period of time, they'll send them back to us because we're the ones that made that original diagnosis. Typically, that's the way it will work. Some reality check for where we are today. We're all living longer as a society. Age-related diseases like macular degeneration are really more prevalent than they've ever been before. Diabetes and diabetic retinopathy is the leading cause of legal blindness in the United States. And that's just tragic because it's from a lack of care with their diabetes. It's people whose diabetes gets out of control. What I would encourage you to do is look for eye doctors that are really up to date on the latest in everything, whether that be technology, whether it's the way that they educate you. The bottom line is that you want that doctor to really see you as a whole person. Not all optometrists practice at the highest level of medical eye care, and frankly, not all ophthalmologists practice at the highest level of medical eye care. And I would encourage you to find a doctor that you feel really comfortable with, but think about, what's their follow-up, what's the time that they do to counsel you. Those are the things that are really important. You want them to practice at the highest level possible. You want them to diagnose and manage those conditions, but feel very confident that they're going to refer you when and if needed appropriately. So my recommendations for an eye exam, I think this is important, not just when you can't see. A lot of people say, oh, I'm doing fine. I see great. I don't need an eye exam. Well, I was part of a program called Infancy, which was no-cost eye exams for children in the first year of life. Typically, we like to see children between 6 and 12 months old. If everything's doing really well, we typically like to see them again at 3 years old and then again at 5 as they're starting school. Then we're going to want to see them at least every year or two based on the recommendation of the doctor. If a patient, if a child is 5 years old and they are showing signs that they may develop nearsightedness or myopia, and both mom and dad are nearsighted, I'm going to probably want to see them every year. If they're seeing really well, they've got no other visual concerns, I may just say, let's see them every 2 years unless there's any concern. For that 18 to 60-year-old, every year or two, depending on previous eye exams, contact lens wearers, we should see them every year. If there's a family history, things like glaucoma, things like macular degeneration, we're probably going to suggest seeing them more frequently, at least every year. High blood pressure and diabetes, obviously, we're going to see those patients a minimum of once a year. Again, based on what we as a doctor recommends. I like to see every patient over the age of 60 at least every year, or as directed. Sometimes I see some of my patients 5 or 6 times a year based on their condition, because they've got multiple things like glaucoma and macular degeneration, and we're waiting for their cataracts to get ready for surgery. So as I kind of wrap this up, I thought I'd share some comments that I've heard over the years of practice. And I think this is really important, and I would encourage you to think about it this way. You know, I want my doctor to take the time to listen to my concerns. For me, presenting like this is a challenge. I like to think of the 2 ears and 1 mouth should be used in that ratio. Listen twice as much as I speak. My job as a doctor is to play detective, ask you questions that you will share everything that will help me make a better diagnosis and take better care of you. The other one I love is I need to feel confident that my doctor will refer when necessary. I've had patients come to me ultimately because they said, you know, they kept saying, oh, I can take care of this, but I keep getting worse. So they come and they're looking for a second opinion. So you need to feel confident that they're going to refer appropriately. And then I've had many doctors say, you know, I've been eye doctors before and they see me as just 2 eyeballs. They don't really talk about me as a person. Are they really listening? And then a really good friend of mine, a colleague, Dr. Jeffrey Gerson, we talk about diabetes. You know, a patient who has diabetes is not a diabetic. They are a patient who has diabetes. Well, if you have macular degeneration, you are not a macular degenerate either. So with that, I'm going to close this up and happy to answer some questions. But my bottom line is find an eye doctor that treats all of you, not just your eyes. And I really believe that. Our tagline is we care for people, not just eyes, in our practice. And I hope that you will be able to find an eye doctor that will treat all of you and not just your eyes. So with that, I'm going to end my presentation and hopefully answer any questions you may have. All right. And I see there are a few in here. So the first one from an anonymous. My optometrist has sent me to another eye doctor who is treating my glaucoma. I keep asking if I can see my optometrist and he keeps saying no. Why would that be? That's actually kind of interesting. I would be surprised in that situation. Apparently, you know, in this case, the optometrist was not an optometrist who treats glaucoma. I'm not sure what state you're from, but in fact, I think in this situation, I would just ask them, you know, at least for eye care, for my vision care, can I go back to my optometrist if the ophthalmologist is treating the glaucoma? That's not a very good, what I call co-management relationship. Now, another question, is there any other way to get a comprehensive eye exam without my eyes being dilated? Well, I believe that if I can get a really, really good Optomap, provided that you don't have a condition like glaucoma or macular degeneration or diabetes, if I can get a really good quality Optomap image, then I'm pretty comfortable not dilating you. Some doctors don't necessarily feel that way. We typically in our office, if you have macular degeneration or glaucoma or diabetes, we still dilate our patients just because we want to have an even better look. If you have macular degeneration, many of the times I think you would probably, you'd want to be dilated most of the time. But if your doctor has an Optomap, I would say that would be one way to potentially do it. So if you have diabetes, the next question is, I have diabetes, which doctor should I be seeing? I think that's a really good question. If you have an optometrist who is really monitoring your retina closely, just because you have diabetes, until you have any diabetic changes that warrant treatment, I'm not sure that you need to see a retina specialist or anything like that. Good optometrists or general ophthalmologists that are doing great care, that are taking images. One of the things, as I mentioned with the Optomap, I like the ability to zoom in really high magnification and look out in the periphery if you have diabetes. Because if I see little tiny hemorrhages in the far periphery and nothing in the center of your eye, which is the most important part, those tiny hemorrhages out in the periphery are likely going to lead to macular changes or diabetic retinopathy that needs to be treated. So again, I think if your optometrist or ophthalmologist is dilating your eyes and or doing an Optomap and really studying and showing you what they're looking for, I'd feel very comfortable seeing either a great optometrist or a great ophthalmologist, either one. So what are some of the tests that I can expect when having an eye exam? Clearly, every doctor is going to have to check your visual acuity, either just with your glasses on, your current glasses, or without your glasses. If you're going there to get new glasses, you're going to have a refraction. Hopefully that doctor is going to also measure things like blood pressure. In our office, we do blood pressure, we do color vision, we do stereopsis, which is depth perception, if you will. We have to measure the muscle balance to see if your eyes are working together well. If you're over the age of 40, we're going to find out what prescription you need up close. The doctor is going to use a slit lamp, which is like a microscope, to look at the front of the eyes, as well as use a lens to look at the back of the eye, the retina. Hopefully you're going to have tonometry, which is going to check the pressure in your eyes. There's a variety of ways. A lot of doctors still utilize the puff of air, if you will. We utilize one that's a little different than that. And for my glaucoma patients, you may have had a little blue light that touched your eye. Variety of different ways to check the pressure in your eyes. It's called tonometry. Some kind of visual field screening, whether that be confrontation fields with fingers or an actual visual field instrument that they would do. In our office, we like to do an Optomap image on every patient. So you're going to have most all of those tests done on every comprehensive eye exam. And then if you're coming back for follow-up, you may have tests like an OCT, which is optical coherence tomography, which actually allows us to look at the layers of the retina. That lets us look at the macula and macular degeneration. It's one of the ways that we detect going from dry macular degeneration to wet. But I think that answers most of those questions which you have. Next question is, I think I have dry eyes. Which doctor should I see? I would actually, you can go to an optometrist when you're making that call. I would say, does your doctor treat dry eyes? And if all they do, which this is one of my classic pet peeves, is if they say, well, yeah, you have dry eyes, just go to the drugstore and pick a drop. Or if they hand you 3 different samples of drops and say, use whichever one feels better, that's not someone who is really treating your dry eyes. They're just letting you kind of experiment. In our office, we do special testing. Many optometrists and ophthalmology offices do special testing, trying to understand the root cause of what the dry eyes are. It can either be not enough tears, it could be poor quality of tears. We're seeing tons and tons of dry eye. It's called Meibomian gland dysfunction because of all the screen time that we're all doing. When we tend to work on screens, read a lot, if you're an avid reader for many, many years, or an accountant that's been working on spreadsheets, you typically don't blink as often. And you also blink softer. And consequently, the glands that are in your eyelids, the Meibomian glands, kind of atrophy over time. And that secretes the most important layer of tears, which is really causing a lot of dry eye or irritated eyes and conditions. So find an optometrist or an ophthalmologist, but make sure that they really treat dry eyes and not just say, oh yeah, we treat it, and then they hand you 3 samples of artificial tears. I'm noticing that I'm having trouble with colors. Is there a specialized doctor to see? Again, kind of goes back to whether you want to go to an optometrist or an ophthalmologist. Primary doctor is who you want to go to first. Some things with color could be related to, you could have some cataracts that are beginning. A lot of times color issues become a little bit of an issue. There's also some neurological conditions, but hopefully the optometrist or the ophthalmologist, whichever primary eye care doctor you go to, I think they should do some special tests, or at least come up with a reason why your colors are really there. And sometimes you'll think that it's just subtle color issues, like you're starting to have trouble to recognize between a blue or a black. That oftentimes is common with cataracts as they're beginning. So hopefully that kind of answered that. My doctor runs a lot of tests when I'm having my eyes examined. Is this normal? I would say yes. I would say that's a thorough doctor. They're, to really get all of your solutions to all of the potential problems you have or may not even know you have to do quite a few tests to really understand that. And so I would say it's totally fine. I was just diagnosed with dry macular, but I'm being told there is no treatments. What should I be doing? Well, I think the argument number one, it's very easy to say you should not smoke. If you think about the eye salad that I mentioned, try to eat very nutritionally, try to cut down on any fats that you have. I'm a believer that supplements can make a difference. There's supplements out there that are over the counter. There's some that your doctor maybe can prescribe. Not all optometrists or ophthalmologists believe that taking supplements for dry will slow the progression down. I personally believe it will. I've seen it happen just based on tests where we've been able to keep the functionality going. So I would also kind of question, when did they want to see you again? And if they said, oh, we'll see you in a year, I would probably look for another doctor that maybe spends a little more time on the dry macular treating and really managing your condition at that point. The next one is I've been told that I have low vision, but haven't been told what I can do about it or who I should see. That's disappointing, and I'm sorry about that. You could probably, you can look at, go to AOA.org, and there is I believe it's still called the low vision or rehabilitative vision section. Those are optometrists that that have a special interest in low vision. And a lot of times they can help you. I'm disappointed that your doctor who diagnosed you as having low vision didn't recommend, because usually in an area, your doctor should know who that person is to go to. And one of the things that I've learned is that it makes a lot more sense to refer you to that doctor for low vision aids when your condition isn't really bad, rather than waiting until it's potentially gets really bad, because it's much better, easier to utilize the aids and learn how to use those aids when it's there. So again, you can also, you can probably just Google low vision doctor in your area and find it as well. What am I looking for when I'm doing the OptiMap? I am looking for any changes that don't look normal in the back of the eye, in the retina and the optic nerve. The nice thing about the OptiMap, it allows me to, the color image is actually created using a green and a red laser that allows me to look at the layers of the retina. So I'm looking for conditions like little hemorrhages. I'm looking for, as one of my patients this morning, a new patient, she has high blood pressure and she has vessel changes in the back of her eyes. So we're going to monitor her. The other reason I like having that image is that it actually allows me to compare this year to next year or to the next time I take an image to see if there's any progression of any kind of a disease. But literally, I'm looking for anything that would be out of the ordinary, documenting it and being able to really monitor it. Like I said, the reason I like it is it allows me to blow things up in very large resolution and allow me to study different parts of the eye. And then the ability to take and to separate the layers is really super helpful. It looks like our last question, and I've been hearing about dark adaptation. What is it and what is it designed to do? As I mentioned, dark adaptation, if you go to Maculogics, MACULOGIX.com, you can learn a lot about dark adaptation. For me, what you're really trying to find out is that what we do is we allow your eyes to get completely dark adapted, meaning you're in a dark environment, and then they flash a bright light, and then it tests exactly how long it takes you to be able to perceive vision again. It's how fast you recover, if you will, from that bright flash of light. The longer it takes to recover, the more compromised the macula is, or the cells in your macula. And that's the generalized way to describe it. But the bottom line is that for us, we're utilizing it to help our patients or help us diagnose before we even see a condition that looks like macular degeneration on the retina. We're actually able to diagnose it subclinically and find out if it's really something to be concerned about. And there are supplements that we prescribe that help improve that night vision a little bit. So I hope that answered everybody's questions. I'm really honored to be here. I will come back at the end if there's any further questions. But for right now, I'm going to stop my video and turn it back over to Larry, I believe. Thank you all very much for allowing me to participate today.
Dr. Keogh, that was fascinating presentation. I thought I knew a lot about eye health. I learned a lot. Our next speaker represents a company and one of our sponsors called Notovision that makes a product she's going to describe that I use every day, that is the Amd Grid on steroids. It will give you an early change in your eyes, and she'll explain in detail what it does. And I'm very excited and proud to have her with us today. Her name is Megan Blicker, and she is an optometrist, an ocular disease residency trained in Nashville, Tennessee. She was executive clinical outcome specialist with Bausch & Lomb Surgical before joining Notovision a little over 2 years ago where he serves as its director of clinical affairs. So it's now my pleasure to introduce to you Megan Blicker. Megan, take it away.
Thank you so much for the introduction. No Vision is proud to partner with the Macular Degeneration Association, and I appreciate the opportunity to speak to you all today. It is such a privilege. To reiterate some of the important points made in the presentation, I'd like to further discuss understanding the importance of early detection of wet AMD and how you can play a role in protecting your vision. 4C Home is FDA cleared and Medicare covered. It's prescribed by your eye care professional when you have the appropriate level of vision and appropriate stage of age-related macular degeneration. It's a form of personalized medicine with the 4C Home device used at home in between your regular eye exams, and it detects metamorphopsia or visual distortions in AMD. AMD is the leading cause of severe central vision loss in people over the age of 50 years in the United States. I'm going to share with you the information you need to get informed and take charge of your vision. AMD is a chronic, meaning it doesn't resolve or go away, progressive, meaning it tends to worsen over time, type of condition. And there are two types of AMD, dry and wet. Dry AMD is the slower changing, earlier form of the disease that puts you at risk for developing the wet form of AMD. And wet AMD is the sudden change or advanced form of the disease. AMD affects an area of the retina called the macula, which is responsible for detailed central vision used for activities like reading, driving, and seeing faces clearly. In dry AMD, changes occur in the cells of the macula, and drusen, or deposits, these yellow spots that you see here on the right side of the screen in the picture, build up in this area. And these changes may induce blurry vision, such as difficulty seeing sharp details both up close and far away. Dry AMD is the slow form of the disease, with changes you may not notice over time. Most importantly, dry AMD puts you at an increased risk of progressing to wet AMD. Over time, the size and number of these drusen or deposits can increase, which increases your risk of developing the more sight-threatening form, wet AMD. Again, dry AMD can suddenly change to wet AMD without any kind of advance notice. If you convert to wet AMD, abnormal blood vessels grow under and into the retina in the macula, as you'll see here on the right side of the screen. These blood vessels can leak fluid, and they can sometimes bleed without any type of warning. You may not notice these changes until significant vision loss has occurred. If you convert to wet AMD, this significant vision loss can be rapid and severe. Symptoms of wet AMD include distortion, where straight lines look wavy. You can have dark spots in your vision, or just generalized blurry vision, as you see here on the screen. Unlike dry AMD, there are effective treatments for wet AMD, but these treatments are most effective when administered early on before symptoms are noticed and before vision loss has occurred. These treatments can halt or slow the progression of wet AMD, but they cannot restore vision that's already been lost. Once the wet disease starts, it will continue to advance until you receive treatment. Irreversible damage can occur within days to weeks and before symptoms are even noticed. But how early is early detection? Once symptoms of visual impairment are noticed, those wavy lines or dark spots appear in your vision, then the vision loss may have already occurred. The earlier you catch wet AMD, the better chance you have of preserving your vision, your independence, and the ability to go about your daily life participating in activities you enjoy. So, wet AMD treatments are most effective when the disease is caught early. 4C Home is an early warning system for your eyes. You use this device at home in between your regular eye exams. It helps people with dry AMD detect wet AMD before you even notice that visual changes have occurred. But how does it work? Well, you take a simple daily test that checks for tiny changes in your vision. The test takes just a few minutes per eye per day. The data from each test is then sent to your eye doctor as well as the No Vision Diagnostic Clinic, the medical provider of 4C Home. If a change in test scores is detected, the diagnostic clinic alerts your doctor. Your doctor's office will then contact you directly to schedule a follow-up visit. The Amsler grid, as you see here on the left side of the screen, was developed in the 1940s and has for a long time been recommended as a simple and accessible tool that you can use from home to monitor the changes in your vision. However, by the time you notice vision distortions on this Amsler grid, significant vision loss may have already occurred. Fortunately, new technology such as the 4C-Home AMD monitoring program has been developed so you can detect tiny changes before symptoms are noticed, and the system reports them to your doctor so you can receive immediate examination and treatment if necessary. Testing with 4C-Home is easy. You turn the device on and look into the viewfinder to begin testing. Then a bump will briefly appear and disappear, as you can see here in the center green circle on the screen. You'll use the mouse provided to click where the bump appeared and then return to this center dot. Data from each test is then sent to the Notal Vision Diagnostic Clinic for evaluation and provided to your eye doctor as well. Regular at-home monitoring is like brushing your teeth. It's just a good, healthy habit you do every day to help preserve your vision. 4C-Home allows you to take a proactive approach to protect your vision. A clinical partner will be with you every step of the way. After the Notal Vision Diagnostic Clinic receives a referral from your doctor, we'll answer any questions, verify coverage, and ship your device. Once you receive the device, the Notal Vision Diagnostic Clinic will walk you through setup and training. You and your doctor will continue to receive feedback from the Notal Vision Diagnostic Clinic. Our team will be sure to verify your insurance benefits and discuss with you prior to your acceptance of the device and prior to getting started with the program. There are low out-of-pocket costs for Medicare patients. So patients with Medicare and a secondary supplement plan could have out-of-pocket costs as low as $0 per month. Patients with Medicare and no secondary supplement plan will pay $15.06 per month once their yearly Medicare fee-for-service Part B deductible is met. Again, 4C-Home is FDA cleared and Medicare covered. Your doctor will send our Notal Vision Diagnostic Clinic the order for you to begin the 4C-Home AMD monitoring program. And appropriate candidates have a particular stage of dry AMD and a particular level of vision, which will be determined by your doctor. You'll continue to test regularly at home. If a change takes place, your doctor will be alerted and have you come in for an examination. In summary, the Notal Vision Diagnostic Clinic works with your doctor to remotely monitor your dry AMD, helping you retain functional vision throughout your AMD journey. I'm happy to answer any questions you might have, and thank you so much. Here's my contact information for your reference. I would love to hear from you. Great, thank you. I think some questions are starting to pop up in the Q&A here. Appreciate your attention. First question from an anonymous attendee is, my mom had dry macular degeneration, but wet runs in the family. How do I get this device for her? I would encourage you to speak to your doctor that you're seeing for your eye care about referring your mom to this 4C-Home AMD monitoring program. We have sites listed on our 4chome.com website as far as finding a doctor who prescribes the device. But I think a great first step would be talking to your own doctor about wanting to take advantage of this great technology to help detect any changes earlier. The next question from an anonymous attendee, why aren't the doctors recommending this machine? It's a great question. I think as Dr. Keogh was saying in his presentation earlier, that sometimes there are technologies or trends that are more available in certain areas. We are a small company and have been trying to get the good word out about this wonderful program. And like I said before, you can go to our website for more information, and then you can help us spread the good word. But first, talking to your doctor is always best.
Next question or comment is, I love the thought about making sure my vision is protected. Can an optometrist prescribe this? Absolutely. Any licensed eye care professional, optometrist or ophthalmologist, which of course, again, thanks to Dr. Keogh, we now know the difference between the two, would be able to prescribe this technology. And that's all the questions I see, unless anyone else has any last minute questions or comments.
Those are excellent presentations. I hope you all learned a lot. And please stay tuned for further educational conferences that we'll be producing throughout the year. All that being said, thank you again and have a good day. Stay well.